أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يقل له كفوا أحد صدق الله العظيم. Today I welcome you all on this weekly sessions of Pakistan Cardic Society academic sessions. I would like to welcome our worthy President, Pakistan Cardic Society, Major General Suhail Aziz Saab. I would also like to welcome our panelists who are with us today, Dr. Amber Ashraf, Dr. Professor Hafizullah Saab, and at the same time, I would like to our panel of experts, including Dr. Qurban, who is the guest speaker for today, and our worthy panel that includes Professor Dr. Yawar Saeed, who is an electrophysiologist in Aga Khan University Hospital, and Dr. Talha bin Nazir, who is currently the head of department of RIC Electrophysiology department. Today's session will be followed by an introduction to the speakers and moderators, a lecture of 20 minutes, which will be followed by MCQs and discussions. There's going to be an ECG corner, and the ECGs will be displayed and discussed according to the examination pattern. I would like to now hand over to our worthy speaker, Dr. Qurban Hussain Khan, who is an FCPS electrophysiologist and cardiologist who has done his CEPS-A and CCDS from USA. He is currently working as assistant professor of electrophysiology at the Rawalpindi Institute of Cardiology. Sir Qurban, Sir Suhail, would you like to say a few words about these sessions that we have started?
Sir, Hafiz bhi kuch comment denge. First of all, I'd like to congratulate all the people who were involved in these sessions. So these are going to be regular twice a week sessions, 9 to 10. And we're going to talk about common things which are interested to the cardiology community, especially the residents and the general cardiologists who practice. Then we will answer simple questions, which will be day-to-day things and also covered in the exam FCPS. We would like people's feedback on the best time they prefer, because eventually you'd want this to be once a week session, because this curriculum is too much and we cannot, like we discussed earlier, make people memorize, but we can give them an opportunity to learn. And so we have one session going on every week where we have different topics we discussed along the format of the FCPS exam, but it's a great learning experience when you follow that system. So without further ado, I'd just like to ask Sir Hafizullah for the comments, and then I'm especially grateful to Hafizullah Saab and Professor Amber for taking part in this activity. And sir, if you have any comments, then we hand over the mic to Qurban Saab.
Let's start with Dr. Qurban's lecture, please.
Great.
Thank you very much, sir. It's an honor to be on this forum. Today's talk is common scenarios in atrial fibrillation. The aim is just to prepare people for the FCPS2 or MD final exam in cardiology examination questions. And also the second aim is to give an overview of AF management from a heart rhythm specialist perspective. We're going to talk about anticoagulation, rate control, rhythm control, ablation, and as mentioned, there'll be an MCQ session and an ECG corner as well. Why is AF important? This is data from Europe. We don't have equivalent data in Pakistan. The lifetime risk of AF in people of European ancestry at the index age of 55 years is about 1 in 3. So 1/3 of everyone is going to get it at some time in their lives. Data from Pakistan is sparse. 6% of all hospital admissions in Karachi acute medicine unit, data collected over a year and a half, were related to atrial fibrillation directly. Let's talk about management. We'll break it down into, first off, management should be patient-centered. The first priority is optimizing stroke prevention. Symptom control with rate and rhythm control comes next. And also management of cardiovascular risk factors and comorbidities. You'll notice their lifestyle modifications, including losing weight and exercise. That's also an important component of atrial fibrillation management. Let's get straight to it then. The important aspects of management. Anticoagulation, very important. This always comes up in specialization exams, and this is going to come up in our quiz as well, so pay attention if you're listening. So broadly speaking, you're supposed to identify low-risk patients first, and you use the CHADS-VASc score, which we're not going to go into. I assume everyone has a prior knowledge of the CHADS-VASc score. C is CCF, H is hypertension, 2 points for age greater than 75, 1 point for age greater than 65, a point for diabetes, 2 points for stroke or transient ischemic attack. V stands for vascular, so you get a point for if you have either an aortic plaque, significant coronary artery disease, peripheral vascular disease, and SC stands for sex. You get a point if you're female. That's important later on. So who needs anticoagulation? You need anticoagulation if you have a CHADS-VASc score of 1 if you're male or 2 if you're female. This is a class 2A indication. So just 1 point, if you're a woman, you get 1 point for being a woman, but any 1 additional point, you should consider oral anticoagulation. Data from the Asia Pacific Heart Rhythm Society suggests that people of Asian origin have a higher risk of thromboembolism than people of European origin. So in clinical practice, if somebody has a CHADS-VASc of 1 if they're a male or 2 if they're female, I typically anticoagulate. What about the Hasbled score? Hasbled score, the way to interpret the Hasbled score is if the score is greater than or equal to 3, you don't not give anticoagulation. You have regular review. You assess modifiable bleeding risk factors, which are all in the score. And that's how you deal with it. If your CHADS-VASc score is 2 if you're a male or 3 if you're a female, then you must anticoagulate. There's no 2 ways about it. It's a class 1A recommendation. And you begin either a NOAC or a VKA. Time in therapeutic range, or TTR, should be 70%. 70% is ideal. So what should we give? These are the European guidelines, and they're very clear. NOACs are superior to VKAs, like warfarin. The only exception to this is mechanical heart valves or moderate to severe rheumatic mitral stenosis. This is a class 1 recommendation, level of evidence A, so you must follow it. Let's talk about rate control next. I think the way to approach this is, for most scenarios, for most AF patients, rate control should be lenient. There's been no difference shown between outcomes in rate control of 110, which is lenient, or strict rate control, which is 80. So for most people, lenient rate control of less than 110 is adequate, which can be assessed by a 12-lead ECG. What about strict rate control? Who qualifies for that? Strict rate control using rate-limiting agents such as beta blockers, digoxin, and calcium channel blockers is for people who have deteriorating LV function, or they may have a cardiac resynchronization device, CRTP or CRTD. So these are the people who benefit from a stricter form of rate control. At the bottom of the slide, we've mentioned that if you have atrial fibrillation, the data is there that if you qualify for a CRT, you should have CRT and also have an AV nodal ablation. And this seems to be a far better strategy for putting in a CRT. Otherwise, the effectiveness of CRT is much reduced if a patient has atrial fibrillation. Okay, now we get to rhythm management, because cardioversion is a rhythm management strategy. How do you know how soon to cardiovert? Well, if the patient is hemodynamically unstable, you know that the patient is a candidate for emergency electrical cardioversion. How do we know they're hemodynamically unstable? You have obviously the blood pressure, but you have other clinical signs such as chest pain, confusion, low urine output, etc. If the patient is hemodynamically stable, on the other hand, the first thing you should do, and generally I think the first thing any cardiology doctor should do when they assess a patient who has atrial fibrillation, is check the status of oral anticoagulation. this is something I'm going to emphasize because stroke is the main, stroke and symptom management is the main emphasis of AF management. And so checking oral anticoagulation status is very, very important. Okay, what about next? Well, let's say you have a patient who has come in with a clear history of atrial fibrillation that you're absolutely sure they had palpitations which lasted less than 48 hours. What's the approach to anticoagulation? Well, you can anticoagulate, you can cardiovert straight away without even thinking too much about thromboembolic risk if the patient had atrial fibrillation onset less than 12 hours ago and no history of previous thromboembolism. So if they are of low risk and they've had no previous thromboembolism and they've had AF in the last 12 hours, which began clearly in the last 12 hours, then you can cardiovert. You should start anticoagulation therapy, but you don't need to worry about, oh, have they achieved a therapeutic range or anything like that. The second category of people you can cardiovert is people who've had AF onset in the last 12 to 48 hours, but they have a low CHA2DS2-VASc score, a low moderate CHA2DS2-VASc score, where let's say for a male, they have one risk factor, they have a CHA2DS2-VASc score of 1, or female, they have one additional risk factor in addition to them being female, and they have a CHA2DS2-VASc score of 2. So you can cardiovert these people straight away. There is another approach where you wait for spontaneous cardioversion, and once again, but you still cardiovert within 48 hours. This is another approach. Once again, if you're cardioverting within 48 hours, you can cardiovert straight away if the AF only lasted less than 12 hours and no previous thromboembolism, or if AF onset is kind of very recent and you've got a low CHA2DS2-VASc score, meaning male CHA2DS2-VASc 1 or female CHA2DS2-VASc of 2. Okay, what about if you don't fall into that category, if your atrial fibrillation has been going on for more than 48 hours? What then? This is important because this will come up in the test, and this always comes up in the FCPS exam. What can you do? Well, I draw your attention to the bottom slide, the bottom part of this slide, where you need to anticoagulate these people. So in every single patient, you start anticoagulation. Then what do you do? Well, you can, if you want to anticoagulate them for a shorter period of time, you can verify that they don't have a thrombus, for instance, in the left atrium or the left atrial appendage, by doing a transesophageal echo. So let's say you want to cardiovert them a week from now. You just do that transesophageal echo on that day, and then you cardiovert them. Or if you want an alternative approach, you can just give them 3 or more weeks of therapeutic oral anticoagulation, either with a VKA or a NOAC, and then bring them in for cardioversion. And this is ideal for people with AF more than 48 hours, or you're not sure, or someone who's had AF 12 to 48 hours ago, but they've got a high CHA2DS2-VASc score of 2 or more in men or 3 or more in women. If you've got moderate or severe rheumatic mitral stenosis or a prosthetic mitral valve, you're not excluded from the pool of patients who should be cardioverted, but you have to come into this category where you need to be either receiving your 3 weeks of oral anticoagulation, or you need to at least start anticoagulation and have a check with the transesophageal echo for thrombus in your LA. All right, let's say you cardioverted the patient. What do you do for oral anticoagulation then? Well, that completely depends on what your CHA2DS2-VASc score is. So after oral anticoagulation and then cardioversion, you are always going to need, in most cases, oral anticoagulation for another 4 weeks at least, if your CHA2DS2-VASc score is 0 or 1 if you're a female. And if your CHA2DS2-VASc score is 1 if you're a male or 2 if you're a female, you're going to need long-term oral anticoagulation. For us, that means lifelong in most cases. So that's something to remember, that you will need oral anticoagulation after cardioversion unless your CHA2DS2-VASc score is very low. Okay, let's talk a bit more about rhythm control. Why rhythm control? I think my plan was to allow some of the panelists to talk about this later. But the bottom line is AF begets AF. The more AF you have, the more microcellular changes in ion pumps, changes in cells, changes in tissues, they sort of build up with time. And gradually the areas in your heart which are responsible for triggering the atrial fibrillation, they become more areas are responsible, and it becomes more and more difficult to control, less amenable to treatment. So the idea is, the theory is, and the data points that if you nip it in the bud, if you grab it early, you get superior clinical outcomes. So how do I know this? Well, in the past, traditional teaching was always, oh, there's no difference between rate and rhythm control. There's no difference in outcome. Or at least they used to say that there was no difference in mortality. But now we have data. We have some good trials, East AFNet 4, 2020, published in the NEJM. When they actually treated patients early with a rhythm control strategy, admittedly, they used antiarrhythmic drugs in 80% of the cases, there was a reduction in MACE, a clinically and statistically significant reduction in major adverse cardiac and cerebrovascular events. So what do the guidelines say about rhythm control strategy and AF catheter ablation in particular? AF catheter ablation is a well-established treatment. It's been going on for a significantly long period of time now. It is safer than antiarrhythmic drugs, and it is superior to antiarrhythmic drugs for both maintaining sinus rhythm and also for symptomatic improvement. So this is a very important concept. This is a well-established, effective treatment. It's safer than medication, and it has a superior outcome to medication. So what does it do? It reduces arrhythmia-related symptoms. You have a quality of life significantly better in ablation versus medical treatment. So let's get a hierarchy here. Quality of life, the best quality of life is the quality of life after ablation. A slightly worse quality of life is the quality of life with antiarrhythmic drugs. And out of the three, the worst quality of life is with rate-controlled drugs. Mortality benefit is still being evaluated, but the data is out there. I'll just show you two more trials. The Qurban trial, it was a major trial in 2018 and 2019. There was a major reduction in MACE following AF ablation in patients with heart failure with a reduced ejection fraction. The Castle AF trial, which looked at symptomatic heart failure, there was an absolute reduction of 16% in death or hospitalization compared to medical therapy. So this compared ablation to medical therapy, which was either rate or rhythm control. So ablation was the clear winner here as well. How do you ablate? For those of us who've seen this in teaching hospitals and cardiac institutes, it's being done in Pakistan, but the cornerstone of ablation is you electrically isolate the pulmonary veins by burning linear lesions around the antrum of the pulmonary veins. You either use point-by-point radiofrequency ablation, or you can use single-shot ablation devices such as the cryoballoon, which freezes the tissue at the ostium of the pulmonary vein. Let's talk about the different modalities now. You either burn or freeze. Cryoballoon has been compared to radiofrequency ablation. The results are similar. The arrhythmia-free survival is the same. The procedure times are shorter with cryoballoon, but there seems to be longer fluoroscopy time. There are some studies which show reduced hospitalization and lower complication rates with cryoballoon ablation, but it's not 100% talked about that cryo is superior to RFA. Let's show you a bit of cryoballoon ablation. This was done by my colleague, Dr. Talha, who's HOD in RIC. And this is a transeptal puncture. There's a transeptal needle and a CS catheter, decapolar. This is the LAO view, and you can see the needle has performed the puncture. Just going to pause the video here. You can see, if you can see my screen, this is the FlexCath 12 French catheter, which has been introduced via the transeptal puncture. This is the balloon which has been inflated. This is what appears to be the left superior pulmonary vein. Now, if you continue to watch, we're going to just go back a bit. You can see that there's a faint outline of a venogram, and the venogram shows a contrast going into the left superior pulmonary vein, and there is some contrast also going down into the left inferior pulmonary vein via a common ostium. So this isn't normal. Normally there are two ostia and separate initial branches of the vein. The balloon has been inflated, typically to -40 degrees, and cryoablation is taking place of the common ostium of the left inferior and superior pulmonary veins. Here you can see the cryo balloon is inflated at the ostium of the right superior pulmonary vein. The CS catheter has taken up into the superior vena cava. That's to assess for phrenic nerve injury. I'm not going to go into that in a great deal of detail, but this is the right superior pulmonary vein, and this is cryoablation going on of the right superior pulmonary vein. This is cryoablation of the right inferior pulmonary vein. Once again, you can see a venogram just to ensure that the vein has been sealed and there's no leakage of contrast. And here the operator was looking for another left inferior pulmonary vein, but it turns out that there was no pure left inferior pulmonary vein, and there was a common ostium which supplied both of the left inferior and superior pulmonary veins. Let's move on. This looks like a complicated slide, but it isn't. How do you treat symptomatic atrial fibrillation? Basically, you've got two options. You either treat with drugs or you treat with catheter ablation. The coloring will help you to understand what class of recommendation it is. So let's go through it one by one. If you've got paroxysmal AFib, if you treat with a catheter without catheter ablation without any drugs, this is a 2A indication. It's something that you should consider. If you've got persistent AFib without major risk factors for AF recurrence, major risk factors for AF recurrence include old age, high AF burden, a large left atrium with scarring, renal dysfunction. These are the factors associated with AF recurrence. Then ablation, first line is a 2B, but if your drugs fail, if your antiarrhythmic drugs don't work, then ablation is a class 1 recommendation. So basically in AF, in most scenarios, if your drugs don't work, ablation is a class 1 indication. Also, I'd like to draw your attention to this part. If you have AF, whether it's paroxysmal or persistent, and you have heart failure with reduced ejection fraction, catheter ablation is first line. Now, I know we see a lot of these patients in OPD, people with reduced EFs and atrial fibrillation. So the thing to note, and very important, and it will come up in the test, is that AF with heart failure, you must ablate. This is a table just going over what I mentioned earlier on, that AF catheter ablation after drug failure therapy in paroxysmal AFib and persistent AFib, it's a class 1 indication. If your antiarrhythmic drugs are not improving patient symptoms, if they're coming back with palpitations and the drugs are not working, then you must ablate. This is a class 1 indication. If your beta blockers aren't working, then it's a class 2A indication. So this is a very, very common scenario, and I think most people fall into this category if you search through your memories. What about first-line therapy? Okay, if you've got paroxysmal AFib, it's a class 2A indication to go for ablation straight away. If you've got heart failure, LV dysfunction, AF catheter ablation is recommended to reverse LV dysfunction. So this is what we're talking about here. AF can lead to tachycardia-induced cardiomyopathy, and if you ablate the AF, you can reverse the cardiomyopathy. And this is a class 1 indication. So this is very important. AF plus heart failure equals ablation. Complications of ablation, we'll just talk about briefly. Very low complications. The best centers have low amounts. The ones you need to be aware of are obviously cardiac tamponade, stroke and MI, esophageal perforation, pulmonary stenosis, persistent phrenic nerve palsy, which is very uncommon. I've met very few operators. Maybe Dr. Tala and Dr. Yaur can enlighten us about the frequency of these complications, but phrenic nerve palsy is very rare, or persistent phrenic nerve palsy is very rare. We'll move on to the MCQs. Does anybody have anything to add on the panel or interject before we move on to MCQs?
Maybe we can have a word from Dr. Yaur and TKS on success of catheter ablation and how many cases does it succeed and what is the recurrence rate? Anyone, TK or Yaur?
So, Assalamu alaikum, everyone. Tala, would you like to take that question and I'll answer a little bit. I'll add in the end, yeah.
Whatever. Firstly, thank you very much, Professor Rizullah and the team. So in terms of success of catheter ablation, what basically depends on it, we have to see what type of atrial fibrillation it is. It's paroxysmal persistent or long-term persistent, and what's the modality being used for the AF ablation, whether it's cryo or whether it's basically radiofrequency. In essence, even in paroxysmal, if the patient has a low CHA2DS2-VASc and is early in detection and early we take him to ablation, we can even get 85% to 90% success. There are some centers with ongoing trials, especially in Europe right now, who are even taking patients off for ablation just after the second episode, whereas they are claiming off more than 90%. Obviously, the data is to come out and it has to be seen, but as per se, as things stand at present, we can consider 85 to 90% of a good candidate with a non-CHA2DS2-VASc with cryo, and cryoablation are pretty much equivalent. So I don't see there's going to be much of a difference. However, when it comes to persistent, with one single procedure, the success in ablation rate as we speak is less as compared to cryo. It comes down to even about 60 to 70%, perhaps even less. Again, it depends on which stage the persistent ablation, atrial fibrillation is at. If it's in the early stages, you would get a slightly higher one. And if it's more of a chronic long-term persistent, which is more than 1 year, then we could be looking at actually, unfortunately, success rates with one procedures of around about 50%.
Qurban assalamu alaikum, Talabai. I think we have some sound issues or connectivity issues, but I think we over time will improve that. I think one of the rules which you need to follow in this comment session is we have a 2-minute rule. So anybody who wants to make a comment needs to make a relevant, crisp 2-minute response to a question, so that, in interest of time, we stay on the target. Please continue.
So thank you, Qurban. Excellent presentation. Thank you all, the moderators and the attendees. I think the one important thing which I'd like to mention in terms of CHA2DS2-VASc scoring is a CHA2DS2-VASc scoring is a dynamic score. So remember, obviously, when the atrial fibrillation patient first comes to you and you do a CHA2DS2-VASc score, but on every follow-up, you have to repeat that. So you have to make sure that you have their diabetes being checked, or you've got an HbA1c, whether they are developing heart failure, what is their age. What I tend to see is that this is being missed. So obviously, and about 3 years ago, the patient has been assessed for a CHA2DS2-VASc score, decided that he's not for anticoagulation, and then he presented later in about 2 to 3 years' time, and he's now qualified for anticoagulation, and that is getting missed. The other question is in terms of ablation for atrial fibrillation. I think the success, and you have to select the patient very carefully when you are going for ablation. And as Stella pointed out, primarily I think patient with paroxysmal symptomatic atrial fibrillation should be offered ablation, considering that they don't have any reversible risk factors. So this is my comment to start with. Obviously, I think we have much other questions as well. So so that's how I proceed for now.
MCQs.
So can we go ahead to MCQs?
Can we see any questions in the question answer session? Is there something which is worth responding to? If somebody could go over those questions and answer them, please.
So we have a few questions, sir. So we have a few questions. I'll share it with you.
So what I'm seeing here is a lot of people are asking questions about use of NOACs or anticoagulation in patients with acute coronary syndrome settings or patients who have had a PCI. So there's a lot of questions on it. So let me answer this. So I think one important thing is that triple therapy, which includes anticoagulation plus dual antiplatelet therapy, is obviously if the patient has an ACS and it is obvious, or if the patient have a primary PCI or PCI due to angina or other reasons, I think. So you can, the recommendation nowadays is you give triple therapy for 3 months. You can give that, and primarily people tend not to use warfarin in these patients because warfarin levels are quite, as we know, the INR can be labile and difficult to monitor. So primarily people use NOACs and dual antiplatelets for 3 months. And after 3 months, you can then switch to single antiplatelet plus oral anticoagulation. However, if the patient did not have an ACS but have a PCI in the past, but not a recent ACS, then the recommendation is that you give them single antiplatelet plus anticoagulation. So that is primarily, I think, about the anticoagulation in the setting of ACS or acute MI settings. So hopefully that's
an excellent comment. Vijat Lodi, you were going over the guidelines on triple therapy recently. Can you give me the guidelines?
So the guidelines were that if the patient is at high bleeding risk, if there's assessed by the HAS-BLED and the DAPT scores, the guidelines recommend that you put the patient on a triple therapy TAT for 1 week, and then you switch it over to a NOAC with a clopidogrel preferably, and then you extend that for a period of 3 months to 6 months, depending on the scoring. And then after 1 year, everybody inevitably who was on a DAT or a TAT inevitably switches over to a NOAC or a vitamin K antagonist, depending on the indication of use. But if the same patients are on low bleeding risk scores, but the chance of them bleeding is less, they can continue with the same regime that Dr. Yawar has just mentioned. Those are for moderate to low risk for bleeding. Then this all is superseded by ischemia risk, sir. If you have multiple stents in, you have stent length that are exceeding, you have multiple overlapping stents. If the patient is having only one viable vessel rep that is not stent, then that overcomes all of these risks. Then you have to tailor it to patient. Then the guidelines are also silent on these as well, up till now.
I think it's a really wonderful topic, and we need to probably dedicate a session for this, which you will. So any other comments, Yasir bhai, which need to be answered in the question or answer session?
So there's a question that says that what if a patient drops his INR to 1, will have to restart the low molecular weight heparin or unfractionated heparin to achieve therapeutic INR again, and then continue to higher dose of warfarin, or just increase the dose of warfarin and no need for. So basically what he wants to ask is that whenever we start warfarin, we know that it has a pro-coagulant phase and we have to bridge it with a low molecular weight with an unfractionated heparin. But in case we don't achieve therapeutic INR in these patients, and after a couple of weeks, we find out that the INR is still 1, do we bridge them again with low molecular weight or unfractionated, or we just simply increase the dose to achieve the INR?
I think anything less than 1.5 means it's not anticoagulated. And so when you put somebody, let's say, on anticoagulation for pulmonary embolism or DVT, you wait till the INR touches 2, and then you stop the heparin.
Sure.
Right. Let's go on to
Any
MCQ.
other? I think let's
No,
move
sir.
on to question now because we are short of time for the MCQs also.
Sure.
I'll begin the MCQs then. What I will do is I will read out the MCQ and we'll wait half a minute for people and then I'll read out the answer, I think, in the interest of time. So we'll start with question 1. 77-year-old man with a history of cabbage 8 years ago and a documented low ejection fraction of 33% presents to the ER with a 6-day history of fast palpitations. The ECG shows atrial fibrillation, which has a ventricular rate of 138 per minute. He is complaining of severe chest pain and his blood pressure is 70/50. Oxygen saturation is 86% on air. What is the next step in management? And hopefully everyone will get this right. The options are IV digoxin, IV vernicalent, DC cardioversion, IV amiodarone, and pill-in-the-pocket strategy with oral flecainide. And let's give everyone half a minute.
Qurban sir, next time when we post these questions, what I suggest is that when you present the history, then you split the 2 slides in the way that the question is there and the history is there in a smaller font, of course, so that people can go back to the question if they need to. This may not require too much recollection, but maybe when you want give people time to read, you have the summary, the question on one side, and the questions are displayed in the same frame. It just make it easy for people to recall and answer.
Okay.
So the answer is C. The patient is unstable. He has a low blood pressure. He has chest pain. He has low saturation. So he requires immediate DC cardioversion. If, on the other hand, this same patient who had 6-day history of atrial fibrillation was hemodynamically stable, he would be commenced on oral anticoagulation, and he would eventually be given DC cardioversion either after 3 weeks of anticoagulation or sooner if a TOE is performed. So that was it. The other options were inappropriate. We're not going to go into them now. Question number 2. A 43-year-old lady with no past medical history of note presents with a 3-hour history of palpitations. Her ECG shows atrial fibrillation with a ventricular rate of 110 per minute. An echo is performed, which is normal. Her blood pressure is 120/70, and she is vitally stable. What is the best management? So 3-hour history of AFib, vitally stable. Options are digoxin for rate control and NOAC. The second option, B, is commence anticoagulation and DC cardioversion. C, IV digoxin infusion. D, amiodarone and warfarin. Or E, transesophageal echo to rule out thrombus. I think everyone's had time. The answer is B, which is commence anticoagulation and proceed for DC cardioversion. So why is that? Well, she has no history of thrombosis. Her symptoms are less than 12 hours. So if you have no history of thrombosis and you have 12 hours of less than 12 hours of AF, you can be cardioverted immediately. The guidelines say electrical or pharmacological, but typically in practice, we prefer electrical after commencing anticoagulation. Note that her CHA2DS2-VASc score is 1 for being female, but even so, it's worth noting. Question number 3. The answer is on here. So following cardioversion in this lady who presented with AF for 3 hours and was cardioverted back into sinus rhythm, what is the best option for managing stroke risk in this patient, noting that her CHA2DS2-VASc score is 1? Your options are A, take a NOAC for 4 weeks, B, take warfarin for 4 weeks, C, take dual antiplatelet therapy with aspirin and clopidogrel for 4 weeks, D, take a NOAC for life, or E, take warfarin for life. 30 seconds. Okay, we'll review the answer. The answer is A, which is taking a NOAC for 4 weeks. Why is that? Well, she does need anticoagulation, or ideally, I think anticoagulation is preferred. NOACs are preferred to warfarin. We saw that guideline. Post-cardioversion, if the CHA2DS2-VASc is 0 in males or 1 in females, then you have to anticoagulate for 4 weeks. If your CHA2DS2-VASc is 1 or more in males or 2 or more in females, then long-term anticoagulation, lifelong anticoagulation, if you will, is the management. Question number 4. A 68-year-old man with persistent atrial fibrillation presents to clinic. He underwent multi-vessel PCI 4 months ago following an anterior MI. His echo reveals an LV ejection fraction of 32%, and his ECG reveals a narrow QRS, so ischemic cardiomyopathy with persistent atrial fibrillation. He is taking aspirin, clopidogrel, atorvastatin, ismo, sacubitril valsartan, empagliflozin, eplerenone, and bisoprolol at guideline-directed doses. He is still complaining of palpitations despite being on optimal guideline-directed medical therapy. This man with persistent AFib and ischemic cardiomyopathy. Which of the following is the best option for this patient? A, add flecainide, pill-in-the-pocket strategy. B, add digoxin, 0.25 milligrams daily. C, add amiodarone, 200 mg BD. D, add verapamil, or refer to the electrophysiologist for ablation. 30 seconds. Okay, answer time. The answer is E, refer for ablation. We know that AF ablation has been shown to have mortality benefit in heart failure, and it is a class 1 recommendation in these patients. So AFib plus heart failure, you must refer for ablation. Flecainide is class 1A antiarrhythmic. It's not appropriate in structural heart disease. Verapamil not recommended in low ejection fractions. Digoxin is not a mortality reducing drug, and ablation has been shown to be superior to antiarrhythmic drugs. So that's the rationale for the answer E. Last question, question 5. 55-year-old man presents to clinic with repeated episodes of AF, which are symptomatic. He has hypertension and diabetes, which are both well controlled. His echo was normal. He is taking sotalol, 80 milligrams twice a day, as well as apixaban anticoagulation, 5 milligrams twice a day. The QT interval on his sinus rhythm ECG is normal. So hypertensive, diabetic, atrial fibrillation, normal echo on medical treatment. What is the next step in management? Refer for AF ablation, A. B, stop sotalol and add amiodarone. C, continue sotalol and adopt a pill-in-the-pocket approach using flecainide as well whenever AF occurs. D, add digoxin to the medicine, or E, ivabradine. 30 seconds. Okay, we'll move on to the answer. Unsurprisingly, the answer is A, refer for AF ablation. Well, we know that he's been on sotalol. So when we know that one antiarrhythmic medication has been tried unsuccessfully in either paroxysmal or persistent atrial fibrillation, you must refer for ablation. So that's 99% of all the AF cases, paroxysmal or persistent. If either one antiarrhythmic drug does not work, you refer for ablation. This is a class 1 level of evidence A recommendation. You must do it. Even if you've tried a beta blocker and you've been unsuccessful in treating your paroxysmal or persistent AFib, then it's a class 2A recommendation, meaning you should consider it referring for ablation. Ivabradine, I've seen it given in many OPD slips. Ivabradine actually increases the incidence of atrial fibrillation. And remember that in paroxysmal AFib, you don't need to consider drugs. You don't need to try drugs. You can go straight away to ablation. And this is once again a class 2A recommendation, meaning you should consider it first line as a rhythm control strategy. And that's it.
If you can have the comments of the panelists on the subject and various questions, that would really be useful. Remember, we're talking about the exam setting here, so we need to have crisp, relevant, data-based, responses.
So thank you, Dr. Sohail. Thank you, Qurban. Nice MCQs. So referring to I think the one thing which has been used quite sparingly is a rhythm control strategy with cardioversion and ablation. So especially in the setting of heart failure, I think patients who have tachycardia-induced cardiomyopathy, patients who are in heart failure, we have good trial evidence now that keeping these patients in sinus rhythm works wonders. And these patients with tachycardia-induced cardiomyopathies are getting to atrial fibrillation and have actually their tachycardia-induced cardiomyopathy got reversed. And even those patients who have, let's say, ischemic cardiomyopathy or dilated cardiomyopathy, their symptoms improve considerably. So what I think is important is the rhythm control strategy and early rhythm control strategy in these patients with heart failure and with symptoms of heart failure should be considered. I think the other important point in the MCQs, as Qurban highlighted, is the use of ivabradine and also the use of the drugs that has got no real benefit. So we have been seen using a lot of, so ivabradine is primarily the drug which works on the sinus node, and as we all know in atrial fibrillation, and primarily the rate control with ivabradine will not work. So please do not use ivabradine in these patients. They actually make things worse. So these are the two comments from me, and we'll take it forward.
In case number 2, Dr. Qurban, it was an acute AF lasting for 3 hours.
Thank you. I pull up just important point slightly. Oh, I'm sorry, I couldn't hear. So Professor Fizola has something to say.
Please
I'm sorry.
Carry on.
Correct. Sorry.
So maybe I can ask a question. In the case number 2, AF patient with AF with less than 3 hours. So the answer was oral anticoagulants and then cardioversion. Why cannot we go for immediate cardioversion with amiodarone, the one that is being practiced very widely all over, and give them oral anticoagulants as well? What do the EP specialists say about that?
No, I'm extremely glad you brought this question up. I think this is where what I wanted to put across as well. When we talk about cardioversion, chemical cardioversion, which you said, why don't we opt for amiodarone? The biggest problem with amiodarone is because which patient should we intervene with in the long-term future, for example, for atrial fibrillation ablation, and who should we decline? Now, this is one point. Problem with amiodarone is we know it has a very, very long half-life. Now, once a person is loaded with amiodarone, sometimes it's very difficult to gauge that was this patient stage, because the effects on this becomes a confounder in determining the exact stage. Now, I can give this example in this way. One can argue, oh, we can give amiodarone, he can come up in the clinics after 6 to 8 weeks, and then you can follow him up and then things. But in true reality, what happens, even if we look at chemical cardioversion, when chemical cardioversion is used, they tend to mean flecainide, they tend to mean sotalol, they tend to mean drugs other than amiodarone. Amiodarone is considered a class 2A, 2B for a cardioversion. Even more preferable is the electrocardioversion. So that's one instance. Now, the second problem, the practicality lies that these patients in our population, as you know, we have a heterogeneity in terms of education, in terms of society, in terms of healthcare. People end up coming to the emergencies. They rarely end up with us in the outpatient. So there have been instances where a plethora of patients have came into the emergency. Every now and then they've received amiodarone. After 6 to 8 weeks, 9 weeks, or 10 weeks, develop AF, and they've came to the emergency, and then they've just loaded amiodarone. Now, the biggest electrical changes, they become progressive, and sometimes these patients end up presenting to the outpatient clinics after several years. And the problem is they have progressed from a paroxysmal, such as atrial fibrillation ablation. It becomes very difficult for us, and obviously I'm not a fan of persistent AF ablation. Long answer, but simply said, I think it becomes a big confounder. And the biggest issue is with our society and practicality as well when we keep it like that. So that's, and from a guideline point of view, it's a 2B, 2A indication where we should consider amiodarone where there is a contraindication to flecainide. The patient has declined electrical, such as even sotalol or propafenone. So obviously then we have to then go for something called amiodarone for this instance. But again, one thing is this, always I ask my colleagues and residents, why do we fear from electrical cardioversion? I've never seen anything going wrong unless one is totally casual and complacent about using the paddles and not synchronizing the currents. If one synchronizes, gives the appropriate therapy, appropriate 150 joules or 200 joules, even in patients with LV dysfunction, having a cardioversion, electrical cardioversion is safer than giving chemical cardioversion. Both ways, patient will be cardioverted. Both ways, a thrombus, if it is to be dislodged, it will be dislodged. So it's not कि electrical झटका एक मिलेगा तो पता नहीं शायद एक physical force भी लगाएंगे तो वो extraordinary thump करके clot जो है dislodge हो जाएगा. So I hope that answers the question as well, sir.
If I could make a comment to Dr. Tala's comments of being quite generous with electrocardioversion, it's pretty fair enough. We in the 4G Foundation Cardic Center have been doing transesophageal echoes on these patients with AF. And it's amazing. We've seen pedunculated clots in the appendage. We're quite used to seeing clots in the appendage in mitral stenosis before we do a mitral ballooning. And I was quite amazed to see pedunculated clots in LA in atrial fibrillation. So the risk of having a clot in the LA is the only issue there is with cardioversion, that if all of a sudden you get a synchronized cardioversion, there's going to be risk of thromboembolism. Having said that, it's a great lecture. I'd just like to add two more things. That one, the world over, the Microsoft Teams is becoming a very common way of having this discussion rather than Zoom. So I request as many people as possible to load on to MS Microsoft meetings, because in there you can have polls also. So, it would be really useful to have people responding to a question and seeing how many got it right, how many got it wrong. And just for feedback, we get the idea. So For one, please try and download MS Zoom, MS meetings. That really help us in getting more education and information out of this session. And we must try and get a stable net as we log in. Please, any other questions? We still have a few minutes. And there was a comment from Professor Sultana Habib, who's a very ardent participator in these meetings, and she felt that there was a lot of EP being talked about. I think we deliberately asked Qurban Saab to talk to us about the EP, even AF, which is relevant to the FCPS cardiology. And I think we do need to know a bit about the success and failure of cryotherapy and various modalities of treatment. So I think the amount of volume was there deliberately so that these things will come in the exam. And these are things which we as cardiologists and who are non-electrophysiologists need to know, how do these things work and what's the latest success rate. I have a quick question. What about the LA occlusion, and does it differ in different devices? Has it been gaining popularity? Where does it stand as far as literature is concerned in various parts of the world?
So thank you, Dr. Sohail. Yes, so LA occlusion therapy, as we know, is coming up as an alternate to anticoagulation. So it is primarily indicated in those individuals in which you cannot anticoagulate. So if you have problems with anticoagulation with a high bleeding risk, then these LA occlusion devices can be considered. The data about it is at the moment is mixed in terms of reducing the bleeding risk and reducing the risk of strokes in patients with persistent or permanent atrial fibrillation. And the data that we have is primarily they compared it with warfarin and not with NOACs. So at the moment, the jury is out about the usefulness of these in place of anticoagulation. Obviously, I think if we have the expertise available about these LA occlusion devices, they can be considered in those patients in which you cannot anticoagulate, and these patients have consistent atrial fibrillation. However, in terms of comparing it in patients in which you can anticoagulate, but the patient don't want to take anticoagulation for various reasons, the jury is still out whether it is a substitute for anticoagulation or not. However, in patients in which you cannot anticoagulate, they can definitely be considered if you have the expertise available.
My interest in this happens because of my interventional activity. You see, you have a CHAD-VAS score, which keeps on increasing with age. And following the CHAD-VAS, you find that, and if you look at the contraindications to oral anticoagulants, they're just amazing. The list is endless. And this risk increases with age. So, with time, eventually everybody would have to come off anticoagulation. And this becomes really relevant when somebody's on a DAPT, although we have stent strategies which can reduce the duration of DAPT, but if somebody gets a stent or needs a DAPT for a stroke or something and he has this issue, then triple therapy becomes a real challenge and has a six-fold increase in bleeding risk. So the success of these devices vary from one device to the other. The learning curve varies from one to the other, and it's a real challenging procedure. And you really need to become very comfortable with structural heart disease therapy before you can master this. So I have a feeling that maybe we've seen this with carotid stenting also, that the trials which have been conducted have not been very robust, not by trained people, and the learning curve of using this device is quite long. So I think we should. There's a lot of future in this, and this probably will become more relevant. For example, if you have a device like you guys ablate the pulmonary veins, one could use the same opportunity to put an electrolytic device there also. But having said that, the puncture of ablation is different than the puncture, the level site of puncture for the pulmonary artery. So those are some thoughts which I thought I need to share. Qurban Sahab, any final comments?
ECG quiz.
Yes, I think we'll do the ECG quiz. These are ECGs that I think will come up in the exam, in the FCPS exam in particular. They came up in my exam at least. Let's start with this one. Have a look. These are the options. Let's just show you the ECG with the options. I think that's best. So the options are A, atrial fibrillation, B, SVT, C, atrial flutter with variable block, D, focal atrial tachycardia, and E, multifocal atrial tachycardia. So let's take 40 seconds to go over that. I think that's probably enough time. I'll just give what my observations are on this ECG. There's obviously you can look at the rhythm strip. There's a variable ventricular rate. In leads 2, 3, and AVF, there's this classical kind of sawtooth pattern to the ECG, to the P waves. The P waves there's no isoelectric segment, so that kind of rules out focal atrial tachycardia. There's a continuous activation pattern. If you follow the, there's a relatively flat descent and a relatively sharp ascent. And this is typical of typical atrial flutter, which is CTI dependent counterclockwise flutter. But the pattern, I think, is the important thing, the big giveaway. People get this mixed up with atrial fibrillation. They shouldn't. You should be able to see the P waves in the inferior leads and many of the other leads as well. The key is the cycle length of P wave. There is one large square between each P wave. The one large square is 200 milliseconds, and so that's that's typically the cycle length of atrial flutter. Atrial flutter is typically kind of 250 beats a minute to 350 beats a minute, which is approximately one large square. So that's how you would know it's atrial flutter. Also, the morphology of the P waves is such that they all look the same. When they all look the same, it's usually atrial tachycardia or flutter. How do you know if it's flutter or focal atrial tachycardia? Well, focal atrial tachycardia, first of all, the rate is slightly slower. It's not as fast as this. And also there's an isoelectric straight line in between the P waves. So I think that's the important thing. It's not an SVT. SVTs are typically regular. They are narrow complex, but they're not like this. Okay, next. Have a look at this ECG. I'll show it to you again. These are the options, same options as before. Look at the ECG again. And let's give you 30 seconds for this. I think this should be relatively straightforward. Okay, the answer is A, atrial fibrillation. And someone may ask, oh, but it looks like a flutter. And these ECGs we get in our OPD every single day. I'm sure Dr. Tala and I get these ECGs every day. I'm sure Dr. Yawar does as well, where they're labeled flutter, but they're actually fibrillation. Why do people label them as flutter? Because they see these, you look at V1, we'll go back. you look at V1 and you see these P waves. Why are they not flutter? Well, we talked about flutter, the cycle length of P waves is exactly the same. The distance between this P wave and that P wave is about 3 small squares, which means the rate of the P wave is 1500 divided by the number of small, tiny squares, and that's 500 beats a minute. That's too fast. If your cycle length, if your atrial rate is between 400 and 700 beats a minute, there's only one thing on the planet that goes that fast, and that's atrial fibrillation. Also, the morphology is different. This P wave is different from that P wave, which is different from this P wave, which is different from this. You can't see the P waves in all of the in most of the electrodes. So that's why it's atrial fibrillation and not atrial flutter or atrial tachycardia. It's too fast. The morphology is too variable. And, you know, atrial fibrillation degenerates as well. It's coarse. This is coarse AFib, and then it becomes fine AFib because it's the nature of the disease, multiple re-entry circuits. So let's do some intracardiacs now. This looks like a intracardiac ECG, 3 surface leads at the top, lead 1, lead 2, lead V1. This is the high right atrium lead. This is his distal, his proximal. These are the coronary sinus leads. This is coronary sinus proximal, which is in the septal wall of the right atrium. And as the numbers go down, you get more leftward. And this is kind of around the mitral valve annulus. And this is the most leftward is the CS1 and 2. RVA is the right ventricular apex. So these are your options. Is it atrial fibrillation? Is it VT? Is it atrial tachycardia? Is it AVRT or sinus tachycardia? 30 seconds.
Maybe, Dr. Qurban, we need to have a separate session on EP studies, tracings for FCPS, because they will be asked, but they're quite Latin to all of us, at least to me. And so maybe we need to have a session on how to identify them, so one from the other, just some basic knowledge which will be asked for the exam. We need to have a separate session for this.
Sure, sir. So I'll give the answer to this. Unsurprisingly, the answer is atrial fibrillation. Now, why is it atrial fibrillation? What do you need to see on this? Let's go back. Okay, so the way to read these, or the way I read them at least, is I always try to get as much information as possible from the surface leads first. On the surface leads, you should be able to see a P and a QRS. To be honest, you can't really see a P. This is a broad QRS. This is a QR pattern. This is another QRS. So this seems like some sort of aberrancy here, and this is the normal QRS width. So there are 2 QRSs, 2 ventricular depolarizations here. This is the high right atrium. This is approximately where you might see the sinus, where you might find the sinus node. And there are how many atrial beats? 1, 2, 3, 4, 5, 6, 7, 8, 10, I think. So there are 10 atrial beats and 2 ventricular beats. Okay, that's fine. So that could be atrial. So if there's more atrial beats than ventricular beats, that could be atrial fibrillation. It could be atrial tachycardia. It could be atrial flutter. It could be a few other things as well, a few rare entities. But broadly speaking, for the FCPS, that's what you need to know. How do you know this is atrial fibrillation and not atrial flutter or atrial tachycardia? The morphology of these P waves, and also you can follow the P waves of these, these atrial electrograms. Atrial electrograms is variable. There'll be atrial electrograms prominent in HRA and also in the coronary sinus as well, which also contains ventricular electrograms. But we're focusing on the atrial electrograms. So I ask you to look at HRA distal. This is different from this, which is different from this, which is different from this, which is different from this, they're all different. Also, there is cycle length variability in between these atrial electrograms. So that's the great giveaway. There's more A's than V's. The A's are different in morphology. The cycle length in between A's is very, very variable. And it basically looks like a big mess. It just looks like lots and lots of some kid has taken a crayon and just drawn whatever he or she has felt like. And that's basically what I think the best way of thinking about atrial fibrillation is. If you're absolutely stuck in the exam and it just looks like a chaotic atrial electrograms in the atrial areas like HRA and CS, which has atrial and ventricular, and the ventricles are well organized, just if you hazard a guess, then it's probably atrial fibrillation. Okay, next, this is case 4. This is the electrogram. I'm going to show you a sort of a shortened version of this electrogram later. Options are, I think, exactly the same. No, they're different. AVNRT, VT, atrial tachy, AVRT, and sinus tachycardia. So this is these are the surface leads, 3 at the top. This is high right atrium. And this is the CS proximal all the way down to CS distal, which is the left-hand side. So we'll take 30 seconds on this.
Again, Dr. Qurban Sahib, it's going to be Latin to all of us, at least to me. So I think if you give us the solution and
sure,
you know,
sure. I think we'll give the solution. Okay, what do we have here? We have 3 ventricular beats, 1, 2, 3, and we have look at the high right atrium as a kind of guide. 1, 2, 3, 4, 5. So there's more atrial beats than ventricular beats. So if there's more V's than A's, it's probably ventricular tachycardia. If there's more A's than V's, it's an atrial arrhythmia, more either atrial tachycardia or atrial flutter, or also atrial fibrillation. And fibrillation, we've seen, it's a crazy disorganized mess. And I think that kind of gives you, they're well organized. There's a fixed atrial activation pattern. Normally, the leader in the atrial activation pattern is in sinus rhythm. Usually you have the HRA is leading. The HRA comes before all of these other proximal and distal leads. And the activation pattern is different. Usually CS proximal comes first, then as you go further out towards the left, the atrial signal is delayed. I know it probably, as General Suhail said, if you've not come across this kind of stuff before, or you don't do it on a regular basis, it does seem like an absolutely foreign language. But the principles are very simple. As I said, go to the surface lead, see if you can pick up any hints from the surface lead. Look at the P and the QRS on the surface lead. And you can see, if you look at V1, there's the QRS. I think there's a P here. This is the T. This is a P. This is a QRS. This is a P. This is a QRS. This is a P. This is a QRS. 50 to 60% of the information you need is on the surface ECG, which is blown up. So just bear that in mind when you're interpreting. And then obviously to confirm, you can see that this is definitely a P because this is an atrial electrogram. This is a P because this is, so there's more P's than QRS's, more A's than V's. They're all the same. The cycle length is exactly the same. The signal morphology is about the same. So it's an organized rhythm. It's atrial tachycardia, whether it's flutter or focal atrial tachycardia, it doesn't really matter at this stage. But more V's than A's is ventricular tachycardia, more A's than V's is an atrial arrhythmia, either atrial tachycardia, atrial flutter, or atrial fibrillation. That's the key to know. And atrial fibrillation is very disorganized. Okay, let's show you a device tracing now. A patient who had a pacemaker installed last year comes to you complaining of palpitations. This is his pacemaker readout. This is his 12-lead ECG. This is the atrial electrograms. These are the ventricular electrograms. And just to give you a bit of extra help, as always in the printout, the markers are given here of this pacemaker readout. So pacemaker interrogation. So your options are pacemaker mediated tachycardia, VT, AT, AF, and sinus tachy. So hopefully you can see the relevant information. This is the ECG, this is the atrial electrograms. Here is the ventricular electrograms. We'll give you 20 seconds because it should be straightforward. Okay, I think that's enough time. You can see the atrial, from the marker is the easiest thing to look at. A sense, it can't pace. It's always going to sense at this kind of speed. The pacemaker is not going to pace faster than this. So there are so many more atrial beats than ventricular beats. The atrial beats, how much space is there between? There's two small squares between them. Two tiny squares. One tiny square is 40 milliseconds. So how do you know what the cycle length of this atrium is? Of this, the atrial cycle length, it's 1500 divided by 2. This is going at 750 beats a minute. The atria is beating at 750 beats a minute. There's only one thing on earth that goes that fast, and that's atrial fibrillation. So the other thing to note is the cycle length is variable. The distance between this and this is different from this to this. The cycle length in between each atrial beat is variable, not that easy to see here. And the other thing is that the morphology is different. The morphology of this is obviously different to that, which is different to this, which is different to that. So variable morphology, very, very fast speed. You know, if you're still looking for clues, there's a variable ventricular rate as well, which is also quite fast. So this can only be atrial fibrillation. And that's the end of the quiz. Thank you very much.
Thank you, Dr. Qurban. You have made the things easier because the answers which are coming and we are seeing, most of the trainees, they are giving the right answers to those who are participating. Thank you. And especially for this intracardiac ECG tracing, if you have just given us a normal intracardiac and then you go on atrial fibrillation and all this, it will be easier for even all of us and for the PGs as well. Thank you for a wonderful presentation.
Thank you, Dr. Qurban, Dr. Tala, Dr. Yasser, Professor Hafizullah, Dr. Amber, and all the wonderful participants.